Okay, so I'll just start by welcoming everyone here present in person and then also via Zoom for our, I think this is the third or fourth year of our combined Ortho-ID meetings. It's been very useful up to now, not only the combined meetings, but also the input we get with our antibiotic stewardship rounds that we started after our first meeting. So welcome to everyone from ID, and then we've got a few people who's going to present a sort of a variety of talks this afternoon. And I'll hand over to Norge, who will start with just some feedback from the antibiotic work group at Groote. I'll just share then.
Okay, I just wanted to basically inform the orthopedic guys, because I don't think you know about it, but there is an antibiotic stewardship committee that looks at antibiotic usage across the whole. Is that not your one? Okay. The committee looks at the antibiotic usage across the whole hospital, and we have been attending, I've been attending those quarterly or every 2-month meetings for the last few years, and that's where our sort of involvement with microbiology and infectious diseases on these Friday rounds kind of began. And I realized I haven't really ever fed back specifically to the department in a separate forum about that. So we will probably do at least twice a year, or maybe after every meeting, a feedback at consultants, the monthly consultant meetings, and then perhaps going forward we might just have one session at the combined ID meetings where we just sort of highlight any perhaps changes in trends. So I just wanted to share with you a couple of the slides that we go through and that pertains to us in the orthopedic section. So this is what I get sent before the meeting, so that we can go through it or I can have a look at it and then have any comments during the committee meeting. The antibiotics consumption is divided into 3 groups based on this AWARE index. Access our first and second line antibiotics, and watch list are antibiotics corresponding to the highest priority agents on the list, critically important antibiotics for humans, and the reserve list are last resort antibiotics, and they color code these, green, yellow, and red, and then there's just a list of the examples of antibiotics that are in each of the groups, and then we get graphs like this for each of our areas, showing the different financial year quarters, going, so you can look at any trends. So D14, for example, you can see that there was an increase in the red reserve list antibiotics over a few years, and then it dropped down. And so we kind of monitor mostly trends that are happening across, and then try to explain reasons for that and make sure that it's appropriate antibiotic usage. Fortunately, we are, maybe I don't want to speak out of turn, but one of the better departments in terms of antibiotic stewardship, because we involve mostly all of our bone and joint infections involve long-term antibiotic usage, and so we always consult with Micro and ID to get best advice.
What is the green?
So the green are the access antibiotics that you can prescribe. Well, there's not too much concern about those antibiotics. Then yellow, like second line, and the red are the antibiotics that we reserve. And so we've had spikes of highly resistant infections, which a few years ago or last year, I think we had a bad run. We had a couple of patients that died actually with colistin resistant, multi-drug resistant bone infections.
So it doesn't reflect poor management. It just reflects what the bug we were treating.
No,
that's
exactly.
what it's reflecting.
Exactly. So, yeah, so I'm sorry, those online, if you haven't seen it, the micro and ID guys will probably know these well, but the orthopedic guys are mostly here in the room. But yeah, Steve, so they just reflects, it basically just trends so that you can get an idea as to what's happening prescribing wise. And the data comes from here. You know, they get the data basically from the clinical system, and then present your DDDs, or the divided daily dosages per 100 patient days, and then they list all the antibiotics and how much of which you're using. You know, so orthos, we've always got a big spike of clocks and the typical bone antibiotics.
Just as Steve, it could be poor management if it's not.
It doesn't reflect good or bad.
because
All it tells us is what we give.
Tell
all those restricted ones were appropriate.
Yeah.
It's not bad management.
Yeah.
But it's just not.
But it also gives concerning trends, because if they are all appropriate and we're using more and more of them, obviously it means that there's not all those infections occurring. So, and I think, yeah, there's not much.
So that would hit.
It's mostly Maritz and now that there's the bone and joint infection unit, it'll all be Maritz.
But inherited from across the department, I have to mention.
So yeah, so there was it's just really FYI for your information that that is going on in the hospital. And I think orthopedics, we're quite good in terms of, you know, trying to stay on top of it and prescribe appropriately. Probably just because we, you know, don't really want to get too much involved in the prescribing, so we kind of outsource to Micro and ID, which is, makes us good.
There's a question here from Prof. Mendelsohn.
I know. Thanks very much, Mark, for presenting that. Really just a couple of comments. I mean, Steve, you know, you're all quite right. This doesn't really tell you about the appropriateness of antibiotic prescribing, because that obviously depends on the bacteria, the site of infection, and many other issues. But what it allows is a trend analysis, and that's, you know, this is only half the story, obviously. This is looking at antibiotic consumption in total. We also have discussions around, you know, the resistance profiles and potentially outbreaks in the hospital. So it's it's part of it. The importance of the AWARE index relates to, you know, the fact that the access antibiotics, these are not okay antibiotics. They are the narrowest spectrum first and second line antibiotics for 25 infection syndromes across, you know, all different parts of the body. And the aim is that you would use access antibiotics. But clearly with multi-drug resistant bacterial infection, XCR infections, and some of the infections you're seeing, you appropriately would need to use either watch group or reserve. But it is a useful indicator, because if you do follow it quarterly, you can start to see where there are problems in the hospital and in specific wards, and that includes orthopedics. So you have to interrogate the data. But in general, the WHO's benchmark for countries is that 60% of all antibiotic prescribing should be access. And in fact, in the community, it probably should be 80%, because most people should be on, you know, normal narrow spectrum penicillins. And as a hospital, we're trying to redress that. The only other issue to say is that that red category, the reserve category that Mark presented, is the reserve category. But actually for South Africa, we have so few of those drugs available that a realistic reserve category would probably, should probably have meropenem in it and imipenem, so second generation carbapenems. And if you actually redo it in that respect, the red category, the reserve category, last resort, is much greater than it would be if you didn't. And so actually the true picture is slightly worse than we're seeing. But it's a useful analysis, particularly in trend. but it doesn't tell you about the appropriateness. For that, you have to do a point prevalence survey, which we are planning to do later in the year for the entire hospital, where we will be asking whether the antibiotic is appropriate or not. Thanks.
Wonderful. Hi, everyone. My name is Terry Papavonomos. I'm the ID fellow at UCT in the Department of Medicine and Infectious Diseases. So today I'm going to be talking about a granular problem. It's a patient that we recently co-managed with Orthopaedics as well as with acute care surgery. So we have two cases that I'm going to present. So the first one is a 42-year-old male. He's employed as a truck driver. He's HIV negative. He's got type 2 diabetes with a very poorly controlled picture with an HbA1c of 14%, but luckily no target organ damage. And he was obese and presented to his GP with a painful back, and his GP gave him some analgesics here.
Sorry, Terry, we can't see your slides.
Sorry, doctor.
Thanks.
Can you see them now? Okay, great, thank you. Okay, so I think we all heard the history so far, but importantly, there's no history of any trauma to his back, and I'm going to show you his CT scan. Okay, wonderful. So because he had this non-specific back pain, the acute care surgeons did a CT, and as you can see over here in the rectospinal muscles, it looks like there's a multiloculated abscess, and it was quite extensive actually. And importantly, there was associated osteomyelitis of the right rib and an associated pleural effusion, which we thought was most likely due to a neighborhood inflammation. Unfortunately, the effusion was too small to tap. We probably could have tried to do an ultrasound, but to try and go in there clinically, I think would have been dangerous. So we opted not to. And the second gentleman that I'm going to present is a 50-year-old male. He's HIV negative. He lives in Plettenberg Bay, and he lives in an informal settlement over there. He's employed in the construction industry. He's got plenty of contact with any animals around the area. And his hobby was to play soccer up until when he presented, up until his first presentation in 2013. So he complained to us of this persistent left knee swelling, which had been there since 2013. He'd been to a number of healthcare providers since then, in 2014, 2015, 2016, and then he was referred to George Hospital in 2017, where a few biopsies were done, and he was referred to GSH in 2018. And I first saw him in the clinic, and notice that if you just look over here, you can see that there looks like there's quite a few ulcers on his legs and over there, but actually in actual fact, if you look carefully, there's actually sinuses where they're coming, they're actually sinus tracts. And I think you can appreciate even better, you can see over there. And I said to the gentleman, I said, so what comes out? He says to me, no, doctor, it's sugar that comes out. I said to him, okay, so what color is the sugar? He says, no, it's yellow. So I was like, okay, this is a bit unusual. So then we said, okay, let's just do a few x-rays and let's see what we can find. So I think I'd be the inappropriate person to talk to about what we can see over here. Just want to close this for a second. So obviously this is his knee over here, and as you can see, there's some osteolytic lesions over there. This was in 2017 when he first presented to George Hospital, and then in 2020 when I saw him in December, this is what his knee looked like. As you can see, it's a lot more destruction, a lot more osteolytic lesions all over. And clinically, as you saw on the previous slide, he actually had a lot of swelling. So I'm going to go back. As you can see, if you look at his normal knee, it's not a big guy. He's probably my size. And you can see this marked swelling, a soft tissue swelling over there. Okay, and then here's these AP view, and then once again in 2017, yeah, you can see there's some osteolytic lesions, joint space narrowing, fibula is definitely more infected, and then over here it's almost complete destruction of the joint. Joint is definitely much smaller and lots of osteolytic lesions again. A very angry looking joint. And then this is his MRI. So in 2017, there was extensive periarticular swelling and a lot of edema of the bones and soft tissues, lots of multiple sinuses, and then abnormalities noted in the cortical areas. I tried to put the images at the same level, but unfortunately I couldn't. And one of the problems was because of this contracture, couldn't get it at the exact angle. And once again, you can see all these osteolytic looking lesions. Okay, so what's been going on? He's had multiple surgeries in private. He was told his doctors did surgeries over there. They said, no, don't worry, we'll give you some antibiotics and it will get better. And I think he did say to me, it did get better, but not really that much, and kept on presenting and presenting. And then was referred in 2017 at George, and synovial biopsy, non-specific inflammation, no granulomas. Again, histological report on the 2018 subacute synovitis, no granulomas. Biopsies taken. TB is not, it doesn't look like it's TB. As you can see, the culture is negative on 4 specimens, gene experts negative 1, fungal culture is negative, and then on 1 sample, we grew this Staphylococcus capitis. Well, what are we going to do about that 1 sample? Probably a contaminant. So then we were like, oh, now what's going on? So then this is when I called Prof. Loebscher. I'm like, oh, this is a very interesting gentleman. Please, can you come and take a look? This was in the clinic. And we were scratching our heads thinking, well, what could this be? So put you out of your misery. And the first gentleman, when they did a PCR on the soft tissue swelling, so on the abscess that they drained, he actually grew an actinomyces species. And if I'm not mistaken, his specific one was actinomyces odolinticus. And we treated him, which I'll tell you a little bit more about now. And then the gentleman, which I showed all the images of the knee, we identified it on biopsy, which I'll go into now. Okay, so these are from Dr. Studd at Anatomical Pathology. She's obviously way better at describing it than I am, but I'm going to have a shot at it. So this is, these all over here are these granules, and what you look for is these branching filaments that go out like that. And you're going to say, well, what? It doesn't actually project that nicely over here, but this is purple, and these are all, this red-looking areas over here are actually all pink. And the pink areas are actually thought to be eosinophils or antibody-antigen complexes. And this is specifically what the guys will look for in anatomical pathology, and they'll say this is what we call splendor Hoopley phenomenon. So it's quite a nice term to describe this, and basically all of this is your granule. So another way of diagnosing this is actually taking the granule and culturing it, and this is basically what you'll find in the granule. This beautiful picture over here, which was noted. Okay, so let's go a little bit into what actinomyces is and the microbiology behind it. So as you can see, there's quite a lot of different organisms involved, and the actinomyces, Israeli and Mayeri and odolinticus are the ones that are mainly associated with disseminated disease. And in this cohort over here by Stenger et al., they noticed Mayeri is the most common, but in other cohorts, they'll actually show that Israeli is the most common. And to have disseminated disease, let me just tell you, is exceptionally rare, very, very unusual. And then now you're going to say, well, sure, this is a rare diagnosis. When am I ever going to see this in my life? So it was quite weird. We literally saw these people probably a month apart, but I'm sure we're not going to see them again for a very long time. So when should you be suspicious? So it's a patient that comes in with this chronic problem. Oh, I've got this back pain for a long period of time, or as in the case of the knee fusion, the gentleman was complaining of it being there for about 7 years, and ugly looking area with this masses and then lots of sinus tracts, granules. It's important to actually ask him what color is coming out. The other day I had a patient that we were consulted on from acute care, and it was this gentleman from Congo, and he said to me, no, but doc, you know, my leg is swollen, and he says, I'm seeing black granules, but actually that wasn't, it actually landed up not being a Bacteriophage. We referred as it a Bacteriophage, but actually it was actually just Kaposi sarcoma, and he was just seeing necrosis. So don't get fooled. What I'm saying to you is don't get fooled by if a patient says, oh, there's definitely granules coming out. It might not be that. Just think of it broadly. It could be other things as well. And interesting enough, that gentleman had Kaposi sarcoma endemic, which is not HIV related. Anyway, I digress. So then you get progression through tissue planes and refractory or relapsing course after short courses of antibiotics. And as he said to us, he said, Doc, my leg got better, and then it got worse. So that's exactly what we had in these cases. And then you're going to say, well, where would I see these patients? What areas? So oral cervical facial is seen in most cases, 50%. Thoracic, abdominal pelvic, and that's can be found in females with IUCDs, intrauterine contraceptive device. And then our patients, musculoskeletal, and then really seen in CNS or disseminated disease. I'm not going to bore you too much with this, but I was told when I started ID to always ask what color is the granule, because the granule will tell you what is the organism. And he said to us, well, Doc, my granules were yellow, and there's actinomycosis. Okay, but as you can see, there's a lot of other bugs that can cause it. And these are just the names that I could pronounce. So these are the ones I chose. There's a lot more. So actinomycetoma, bacterial causes, mycetoma, true fungal. So don't get confused with mycetoma. Mycetoma is, we always think fungal, but actually this is bacterial causes over here. And then, as you can see, black granules, pale granules, fungal causes over there. And then just to go back to that beautiful picture that we saw from the pathologist, this is Splendor hoopli. Don't say, Splendor hoopli, it's actinomyces. Not to say, it can be other stuff as also. Parasitic infections, cutaneous larva migrans, schistosomiasis, bacterial causes, nocardia, actinomyces, bacteriomycosis. I have seen patients with nocardia present with abscesses also around bony areas, not common. And then fungal infections as well, aspergillus, blastomycosis, and then this Melissaceae folliculitis. All right, and then let's go through, well, what antibiotics to give. So this paper was in 2016, and they basically showed that ampicillin sulbactam, so this is similar to what we give is co-amoxiclav, all of the isolates out of the 392, so 360 in this, 360 of the 392 isolates of actinomyces were all sensitive to ampicillin sulbactam. Another option is to go down the tetracycline route. So in our case, you can give doxycycline. And then I've highlighted this over here. So metronidazole, not a good idea. Very, very small numbers were sensitive to it. And then again, the quinolone is not a great option. And then importantly, penicillin. We all ignore penicillin, but it's actually a pretty good drug, and especially for actinomyces. All the isolates, 89 out of 89 were sensitive to penicillin. Okay, and then, well, I thought to myself, hang on, why did Stanford, and this is our antibiotic guide that we use, why did it say 2 weeks IVI and then change to an oral? Why can't we just go straight to an oral regimen? So the data surrounding that actually isn't very good at all. But from what I could read from this article, 40 patients in a retrospective analysis. So if you look over here, 16 out of the 17 patients had surgical and antibiotics and had a favorable outcome, but 3 patients didn't receive any antibiotics. So potentially you could tell me, well, okay, so surgery was fine, just plain old surgery, cutting out source control helped these patients. If you look over here, 18 out of the 23 were given antibiotics alone and had a favorable outcome. So what happened to the other 5? So the other 5 needed further surgical intervention, okay, to source control. And then they looked at those patients and they said, but why did those patients fail? Why did they need surgery afterwards? And that was why, because they only received 0 to 2 days worth of IV antibiotics, whereas the others received longer durations of IV therapy. So once again, I'm saying to you, data is not great, but it does recommend that we give longer duration, IV therapy first, and then changing to an oral regimen. And in this article, they made specific recommendations that patients that have had diseases for longer durations are more likely to fail therapy. So as an old gentleman over there for 7-8 years of having this leg, I'm sure he needs prolonged therapy, and we did give him IV therapy for 2 weeks. Okay, and then this was a nice article was by Sudhakar et al. A bit old, 2004, but I thought it was pretty good because it goes all the way back to 1945 until 2003 and looked at what antibiotic therapy they gave. And what I found hilarious was back in the day, they said they gave massive doses of penicillin of 100,000 units. And as I'm sure you all know, that's actually a minuscule dose. For our neurosyphilis patients, we give 6 million units, 6 hourly. I just found that quite funny. And as you can see, mean duration of treatment, 31, 46, 14, 49, 84, 36, 32, who the hell knows? Okay, no, there's no consensus, but what I'm saying to you is that we should consider giving longer duration of treatment for these patients. So let's go on to this. So now duration of treatment, well, how long is the patient have symptoms for? As I explained earlier, the longer, more likely to need longer course of duration, extent of the disease. The oral cervicals are in a small area, small drainage. You could probably get away with a shorter duration. And then as I said, in the area, which is the oral cervical, then did you debride the area as well? Debridement, we all know this. Source control is one of the most important stewardship mechanisms that we have to try and decrease the amount of antibiotic use. And then obviously you need to look at the response to treatment. So as I said, there's lots of different opinions. Mild disease, maybe 2 to 6 months. Severe disease, 6 to 12 months. And let me tell you what we did for our patients. So the first gentleman, as I explained, the gentleman with the erector spiny abscess, I actually saw him at the clinic 2 weeks ago and he was looking fantastic. I did a CRP on him and it was completely fat. White cells were fine. I checked his chest x-ray, no effusion anymore. And that was after 2 months of treatment. But we initially treated him with penicillin, very high doses, as I explained, 6 million units, what we normally give for neurosyphilis, for 2 weeks. And then we changed him to amoxicillin, 2 grams. And at month 2, as I said, he was doing well. I'll probably carry on to about 6 months. That erector spiny abscess was very extensive. So I'm going to give him a little bit more treatment. And then the second patient, we gave high dose ampicillin. Sorry, I mixed my patients around, my apologies. This was the gentleman, sorry, with the knee, apologies. This is the guy that had the amputation. He also had an amputation, apologies. And we gave him penicillin and then amoxil. And then the other gentleman, we went ampicillin IV and then changed him to amoxil. And the whole thing behind these patients is you need to observe them for relapse. So hence I followed up that one gentleman to see what's going to happen. And the other gentleman is going to come to the orthopedic department on, I think now in June. And then I'm also going to see him in our ID department, see how he's doing. Very motivated patient. So yeah, thank you. Any questions?
Thank you. Why do you think that was missed? I mean, do you need to buy? So the lesson from here for me is that this person has multiple biopsies and everything, and we're missing the boat. So should we be bone biopsying when we see pathology like this, or is it not in the soft tissue? Can you not see these changes in the soft tissue? Was it always in bone? And is there a special culture that we should be using for it? Was it only diagnosed very often on histology?
Sure.
So
thank you.
Yeah.
So with regards to the culturing, it's super difficult to culture this organism. So on the first patient, we actually had to do a 16S PCR, which looks at a whole bunch. It looks at the genetic material, and basically we were able to identify the actinomycosis based on genetics. And
so if you do a 16S mRNA, that globally looks at all of them, including actinomycosis.
Yes. Yeah. And that first patient was more than 99% homology, which is saying to us that we're pretty sure this is actinomycosis. Culturing it is not easy. So hence in the second patient, the diagnosis was actually made on a histological basis, where they saw that splendor-hooply phenomenon. Now, as I said, this is a patient, these patients are chronic. I'm not going to point fingers at the people that were treating the patient in the first place. I think it's not an easy diagnosis to make. And I think it needs a lot of multidisciplinary people to come in, because I think when Prof. Loksha and myself saw this, we were like, sure, this is going to be either fungal or it's going to be one of these filamentous bacteria. And I think that's because we've seen it before and you can identify it.
There's some questions from Chad and Prof. Mendelsohn just before. I mean, I think the sad thing with him is he's been sort of seeking care since 2013, and even in 2017, when he had his first MRI, he had almost a normal joint, just a small amount of bone. Obviously, the disease progression is notoriously difficult, but you look at that from the beginning, and this is something unusual, and those cases should just be referred to ID or discussed, because I think everyone, not here, just a biopsy, oh, it's not septic arthritis, so didn't treat it, you know, but didn't keep looking, you know, so.
Well, isn't it? I mean, it's great about teaching. Our teaching is swab, culture, histology.
Yes, histology,
Obviously,
exactly.
exactly. We just diagnosed it like nocardia a few weeks ago.
That's rheumatology. Rheumatology, as I said, to rheumatology, they had a lot more tests because they thought there's some inflammatory arthritis. And the sad thing is we had to do an amputation. He was still very happy with just having his leg off in the end. And the only thing is, I thought it was a fungal infection because his initial MRI had what's called a dot and circle appearance, which is typical for a fungal infection. But of course, this is a fungal-like infection, even though it's a phage. It's a bacterial infection. Chad had his hand up first. Chad, do you want to ask a question?
I just wanted to comment to respond to the question about the culture and add to Terry's response. So there are fastidious organisms, but we need to know up front if that diagnosis is being considered, so that we can put up specialized stains, specialized media, incubate anaerobically, prolonged incubation, and look out for the characteristic colonies, and the same goes for nocardia. So the reason it might have been missed is that you know, we just hadn't put up the correct media and the correct stains. And then also just to mention, the 16S can also be done on the colonies themselves, so we can speciate them. I'm not sure if it was, well, I'm not familiar with the case. I'm not sure if this one was done directly or on the colony. And then susceptibility testing is not standardized, so it's not, we do offer it for nocardia, but not for actinomyces.
Prof. Mendelsohn also had his hand up. Prof, do you have a question or a comment?
No, it's just a comment. I mean, I think it's a, you know, it's a great couple of cases, and thanks very much for Terry for a great presentation. I mean, I think the learning point here is the issue of granules. I mean, if you see these sort of sinuses, it's always good to ask people if anything's coming out of, you know, what's coming out of them. I mean, granules suggest, and as Terry has pointed out, a number of different organisms. And those granules can be crushed and gram stained as well themselves, and a fairly rapid diagnosis, or at least pointing towards the diagnosis, can be made. So if you see granules, think actinomycosis, nocardia, and some of the others that Terry has shown. Thanks.
And in theatre it was, I mean, you had these multiple sort of small pockets of yellow granules that I've never something where I've never seen before. Only regret is that after convincing the anaesthetist to put it on the table a little bit late, we were so rushed to finish the surgery, we didn't take any pictures. We don't have any pictures to show.
Tell me, why did you decide to amputate? Was it like not
No functioning. The fixed flexion deformity at 60 degrees. I think we decided that even getting him to heal at an acceptable, we still did an intralesional amputation, so it will still be so that he can wear prosthesis because he's a young guy that would have a good function, and he just had no function. He also had a sinus contracture in his ankle because it extended halfway down his calf, and there was no way you could salvage that. It was like a hard tumor, you know.
So in my rich time, operations firm, we had to do a hindquarter amputation. The patient with retractable actinomycosis with an indurated leg with sinuses for years.
It's fantastic to have responded well, but we kept him long here because it's from so far. So a few weeks down the line, his wounds all healed. It's very good straight. He was very happy. Obviously. Yes.
By doing the amputation, is it not a cure by itself? I can see the patient have been for antibiotics for long periods, for 2 months and more.
Yeah, that's a very good question. So if we did here above the level of the infection, amputation for him, you know, that would have been the cure. But
we decided in him, it would have been such a high above knee amputation that he would have not been able to wear a prosthesis and would have had very poor function. So we decided to do a sort of intralesional amputation, because it can be treated with antibiotics, and we've debulked the majority of the infection and just left a little bit, but then he needs antibiotics as well. Who else wanted to?
Just one last thing to mention is the soccer was the clue for us. When he said to me, I played soccer, and I said, so you must have fallen all the time. He's like, all the time. On your knee? Yes, on my knee. I was like, well, that's probably why you got this problem. The diabetic, I don't know. Diabetes itself is immunosuppressed. I don't know why specifically in the back, but yeah.
Does it always direct inoculate, or can it see?
I think you can see it as well hematogenously.
Okay.
I'm not 100%.
So in the back, that wasn't necessarily direct inoculation.
Yeah. Because I mean, this guy promised me, he's like, Doc, I promise you, I haven't fallen on the floor. Nothing's happened. No one's hit me. I couldn't explain that one, but at least the other gentleman could. Thank you.
Thank you very much, Doreen. So something completely different, but also very interesting. We'll have Stefan Opperman from Micro to talk to us about bacteriophages. This right. Yeah.
So good afternoon. I think most of you know me already. Stefan, I guess I spoke to you over the phone quite a few times. So Prof. Maritz asked me that to come and give a bit of introduction to bacteriophages. I guess I have to start with a disclaimer that I presented bacteriophages to the ID meeting last week. And this week I'm more going to focus from an orthopedic perspective. So not delve into bacteriophage vaccines, the multiphage, vectors, etc. And I think sometimes it's a misperception that we as microbiologists, we sit in our ivory towers and look down at you guys, eating ground here and the dirt on the bottom. And I've developed a lot of sympathy and empathy with you guys over the years, having to deal with these multi-drug resistant cases coming to tertiary hospitals. So for me, it's really admirable to be in a department which is open a bit to novel ideas of how to address these multi-drug resistant organisms. So from a registrar perspective, I wish you would walk out here, and when you sit in a conference one day and hear about bacteriophages, you'll probably know a little bit about it, more than a colleague sitting next to you. Or even if you just walk away and see or feel, well, that's pretty cool, and that's good enough for me. Almost needless to say, I'm not an expert in bacteriophages, but I'm happy to share with you what I know. So just to start off with, what is a bacteriophage? So a bacteriophage is a virus, and directly translated, phage means to eat. So a virus that eats bacteria. So it typically has this protein capsule plus DNA, and then it has the shaft section with spikes and these fibers. And the fibers binds to very specific receptors on bacteria. So that can be from porins to pili, flagella, even glycoproteins. So it makes the binding to bacteria very specific. And because it's a living organism from an evolutionary point of view, for every type of bacteria, there could potentially be a bacteriophage that can infect it and lyse it and destroy it. So what would happen is that the bacteriophage will come, it will bind specifically to specific receptors on the bacteria, and you'll see the shaft contracts and it injects this DNA into the bacteria. And this is a form of horizontal gene transfer. I think most of you are more familiar with plasmids, where there's two bacteria with a pillar structure and then sharing of the plasmid. So the specific form of horizontal gene transfer we call transduction. And the DNA will then use the bacteria's mechanisms of transcription and translation to form the new viral components, and then by lysis, break open the bacteria and release it into the environment. So this is just an electron microscopy picture of it happening, the transduction process, and it injecting its DNA into the bacteria. So why bacteriophage therapy? Is it a novel thing? Is it something that's been around for a long time? And I thought the best way for me to explain this to you is by just looking at the history and comparing that to antibiotics as well. So they were discovered way before the penicillins independently in 1915 and 1917, and initial experiments was really poorly conducted. So I always like to give this example to people to explain that. For example, in a village where there was a diarrhea outbreak, they would throw an undisclosed amount of bacteriophages down the village well and just see how many people the diarrhea would result from. Then in the 1940s, as I've mentioned already, penicillin then was discovered by Alexander Fleming and his team. And we also know that a lot of the biotechnology interventions that took place with bacteriophages happened in the 1970s, 1980s. And during that period, we also saw the Cold War coming into play. So Russia, USSR versus the Western world. So a political component, poor research initially, and antibiotics wasn't really conductive to continue bacteriophage therapy. Although most of us know it still continued within Georgia and Russia and those areas. So in 2014, I know these articles are maybe a little bit old, but I think it paints a clear picture. So about 70 million deaths is expected yearly due to bacterial infections. The WHO estimates by 2050, we will have 50 million deaths a year due to antimicrobial resistance. And in this article from 2014, stating that in the previous decade, there was only 4 new classes of antibiotics, all against gram-positive bacteria. So we truly have a problem with multi-drug resistant organisms. And I know I'm preaching to the choir here with all of you experiencing this on a daily basis. And I just wanted to let you take note of this. It's only in 2015, just the other day, that the first research trials on bacteriophages that could withstand peer-reviewed journals has come into play. So really a very new thing and novel thing on our doorstep. So I've wanted to exclude this slide, and for my professor department of Brink somewhere there in TV land, he shared this article with us this week on cephedrocol. So it's a novel class of antibiotic with a cetiophore and a beta-lactam, and it's thought to work great against a lot of our escape pathogens that's multi-drug resistant, including the metallo-beta-lactamases. And Prof. Brink, I'll see your article, and I'll raise you with this article from Lancet Infectious Diseases, also from this year, that's already showing resistance, cephedrocol resistance, and probably more worrying, heteroresistance in some of these subpopulations. So the point I want to bring across to you is we have a problem with drug-resistant organisms. So just to look at bacteriophages and how it works, is there's 2 cycles. So we have a lysogenic cycle, which we call the temperate phage. And we know during this cycle, the DNA that I showed you from transduction is ligated into the chromosome of the bacteria, So that's obviously a concern in terms, so it's called the prophage when it's integrated. And that's a concern when it comes to what they call superbugs. So these genetic elements are being able to be transferred between bacteria. But when it comes to bacteriophages, they're only interested in what they call the lytic cycle, the virulent phage. So you see nowhere in the cycle is the DNA integrated into the bacteria itself, the genome. So when they select these bacteriophages for bacteriophage therapy, we know that they get sequenced quite extensively to make sure that they don't have resistant elements in them, and also not of these ligating enzymes. We're interested when it comes to the host range and also the burst size of the virus for these bacteriophage lytic viruses. Something I just quickly want to mention, I elaborated to the ID meeting last week, but not so much for you guys, is the idea of enzybiotics. So this is a very attractive scenario for pharmaceutical companies. It's very hard for them to invest billions of dollars into a phage which they can't patent, which they can get from the environment. But with antibiotics, which they just look at the license, they can bioengineer them to just have the binding domain, catalytic domain, and then adding with biotechnology a moiety that increases the spectrum of binding of the lysine, the catalytic activity, etc. So this is a very interesting thing for the pharmaceutical companies. Then I want to compare to you bacteriophages and antibiotics. So when we talk about side effects, and I'll elaborate in a couple of slides for you that will come, is that bacteriophages has minor side effect profile. So potentially anaphylaxis due to the endotoxins that's released when the bacteria breaks open, while we know there's multiple side effects when it comes to antibiotics. In fact, they wrote a whole SAMF textbook on all the side effects that you have to know about. In terms of the specificity, we know that they're highly specific with a narrow spectrum because of that specific binding of the fibers to the specific bacteria cell wall. But with antibiotics, they can have collateral damage. They can influence the normal microflora as well and cause disturbances. In terms of dose, I think this is a very interesting as well aspect, is they can self-replicate. Because remember, when they infect the bacteria and release its virus into the environment, they can go infect more bacterial and you get this exponential lysis of bacteria. So that's where the whole idea of a single dose comes in and the definition of self-replicating. Whereas with antibiotics, we need multiple dosages. Selection-wise, it can take weeks to days to select a bacteriophage against the multi-drug resistant organisms, whereas it can take several years for developing a new class of antibiotic. Importantly as well, and you'll see this in the slides to come, bacteriophages can elicit quite a strong immune response, not just in the innate immunity, but also humoral immunity, whereas antibiotics does not create that immune response. And we already mentioned that they are living organisms, so they can alter their structure when there is phage resistance, whereas antibiotics, non-living, can't do that, and there's also the potentiality of cross-resistance. Biofilm penetration, most antibiotics are incapable of penetrating biofilms. We know there's rifampicin and ciprofloxacin, whereas bacteriophages have specific depolymerases that can penetrate into biofilms. So it has been used in the past with infective endocarditis and specifically penetrating into those vegetations. Bacteriophages are bactericidal in nature, whereas some antibiotics is bacteriostatic. And then also finally, they're relatively economical compared to a very expensive and time-consuming process when it comes to antibiotics. So the next thing is I want to show you a case presentation of where bacteriophages was used in a relapsing prosthetic joint infection with chronic osteomyelitis. It was managed in Berlin, actually in Germany. So the antibiotic stewardship in this case is probably not ideal. But after the case, I want to point you to 4 key aspects, which I think is critical when you're going to use bacteriophages in the treatment of these organisms. So this was an 80-year-old lady. She was known with metabolic syndrome, diabetes type 2, hypertension. She had a body mass index of 33 and also a GFR of less than 30 with chronic kidney injury. So the author starts by telling us that she had a long-standing history previously with multiple organisms, multiple antibiotic courses. Unfortunately, they don't explain to us how long it was or what antibiotics was involved, but they do start the story by presenting the problem, namely relapsing right knee prosthetic joint infection with chronic osteomyelitis of the femur after a gunshot injury. And where the story starts is by the prosthesis being explanted, the distal femur resected, and the antibiotic loaded bone spacer implanted. During the same explantation procedure, they also grew from tissue a multi-drug resistant Klebsiella pneumonia and Providentia, which they treated with cefepime and cotrimoxazole during the prosthesis-free interval. So 8 weeks later, they reimplant the prosthesis. They continued ceftazidime avibactam for 3 weeks, as well as cotrimoxazole. At 12 weeks, they feel that there is persistent infection suspected. The right knee is swollen and painful, increased CRP, but X-ray not showing any loosening of the prosthesis, and they discontinued the cotrimoxazole. So after another 2 weeks of stopping the antibiotic, they take a joint aspiration fluid, which shows 2 strains of Pseudomonas aeruginosa. One being pan-resistant, so resistant to all antibiotics, including colistin, and the other one being sensitive to ceftazidime and colistin. So the plan that they make, this is now at week 14, is they remove the prosthesis, they do surgical debridement, extensive rinsing of the area, inserted antibiotics, cement spacer with gentamicin and clindamycin, and then also 4 drains. So one in the femoral, one in the tibia area, which they bore and haul, and the other 2 was in the prosthesis area. So very importantly, during the surgery procedure, and I'll come back to this, they gave 100 ml loading dose of Pseudomonas aeruginosa bacteriophage. In addition to that, 5 ml of bacteriophage solution, 10 to the power of 8, not colony-forming units per ml, plague-forming units per ml, 8 hourly, and they gave that for 5 days. So they injected that into each of the ports that they, tubes that they inserted. They also started the patient on colistin, meropenem, and ceftazidime, which they renal adjusted, and then the prosthesis was sent for sonication. So this is just how it looks. This is where they're inserting the cannules. I think all of you can appreciate the high BMI. And this is where the patient is receiving the first dose solution of the bacteriophage, the loading dose. So samples was taken during the theatre operation. The sonification and for intraoperatively tissue samples showed the same Pseudomonas that was cultured from the joint aspiration. And one of the tissues had a Staphylococcus hemolyticus, sensitive to rifampicin and oxacillin. So they took fluids on day 3, 4, and 5 from those tubes before injecting the bacteriophage, and they found that there was no Pseudomonas cultured, but they did culture a methicillin-resistant Staphylococcus epididymis, which they did not treat at that stage. So now we are already at week 16. The drainage fluid became purulent. They did again a debridement in exchange of the spacer. That same spacer was sent for sonication, but still grew the methicillin-resistant Staphylococcus epididymitis. No Pseudomonas still wasn't found, and they decided to change the meropenem, replace it to daptomycin to try and cover the Staphylococcus. So at week 20, there was reimplantation of the prosthesis. Intraoperative samples were still no growth and culture negative. At week 24, they decided to stop the colistin and ceftazidime due to nephro and neurotoxicity. The office does not mention if daptomycin was also stopped at this stage, and they discharged the patient home on rifampicin and doxycycline for 6 weeks to cover that Staphylococcus. So then we jump 10 months later, where they followed the patient up at an outpatient clinic. There was no pain in the right knee. The soft tissue at surgical site was unremarkable. Mobility was good, and the X-ray showed good position of the prosthesis without loosening. So from this case, I want to address 4 issues now that I mentioned earlier in the time that's provided to me that I think is critical if you're going to implement bacteriophage therapy in orthopedic surgeons, in orthopedic patients, for multi-drug resistant organisms. So the first question is, will bacteriophages replace antibiotics? So you saw in this specific case, they still continued with broad spectrum antibiotics together with this 5 days of bacteriophages against the pan-resistant Pseudomonas aeruginosa. And the common feeling in the literature is no. So phages will always be complement to antibiotics. And there's various theories how they can complement each other. So some believe that there's a fitness cost effect. So meaning that the bacteria has to change not just its cell structures to the bacteriophage, but also to the antibiotic. So there's a costness of fit effect, which is too much for the bacteria. In addition to that, it could also be a mechanistic trade-off. So the bacteriophage saying, okay, I will target the antibiotic-resistant bacteria, and the antibiotic saying, I will target the phage-resistant bacteria. Or it could just simply be a sequential density effect, where just too many role players for the bacteria to overcome. Something that all mention is that regardless of using bacteriophages and antibiotics together, there will always be these bacteria that will escape their mechanisms of actions. And that brings me to my second point. So what is the role of source control and standard of care? So all agree that even if you use bacteriophages and antibiotics, there should be an element of debridement, resection, irrigation, restoring the immune system, etc. And this is nicely shown to us in an article that was published end of last year, a mathematical simulation article. And they looked at the effect of phages plus antibiotics plus the immune system. And we see if we can restore the immune system, we can dramatically decrease the inoculum proportion of these bacteria. So we always have to restore this, and in addition to bacteria and antibiotics, there should be standard of care and source control involved. And I think this is also a nice article indicating this. This was a randomized placebo-controlled double-blinded trial. It had 3 arms in it: antibiotics, bacteriophages, and a placebo effect, the intention to treat analysis. It was looking at UTIs post-procedures. And what they found was that bacteriophages was non-inferior to standard antibiotic treatment. But interesting enough, it was not superior to placebo bladder irrigation. And the authors felt that the irrigation step itself was decreasing the inoculum effect, and just emphasizing the fact that we need standard of care and these source controlled interventions. Something important to maybe mention about this article as well is not just their primary outcomes, but their secondary outcomes, which showed there was no side effects. And currently in the field of bacteriophage therapy in clinical trials, we know that most of them stop at phase 2, so safety issue. We're not seeing large numbers. People want to first establish that it's safe before we will see bigger trials. So that's also the third point. Is bacteriophage therapy safe? So this review article specifically looked at intravenous application of bacteriophages. And like I mentioned in the beginning, theoretically, they can cause anaphylaxis reaction due to the endotoxins released when the bacteria breaks open. So there's lipopolysaccharides layers. And up till date, in what's the day today? The 3rd of June? 4th of June. Yeah, so today, the 4th of June, how many cases of anaphylaxis has been reported in the literature? 0. Absolute 0. The other concern is serum sickness. So serum sickness is when you give a fluid or you give a preparation. It has non-human components in it, so proteins or animal products. And then that causes almost an allergic reaction that activates the immune system. So previously, that was a concern. Even as far back as the 1930s, they knew that when they were purifying bacteriophages, they should not include proteins and peptides. And there was a nice study or nice author, Ork et al. And colleagues, who looked at safety of bacteriophages for over 40 years. And they only found 1 case of serum sickness. Today, we know that the FDA and the European councils is very strict when it comes to bacteriophages, that it needs to be purified. So potentially there's no side effects when it comes to using bacteriophages. And the last question, and I think it's probably most relevant at all, especially when you're going to implement a trial, is that what is the reason for a loading dose? How many plaque-forming units per mole do we actually have to give the patient? What's the frequency that we have to give it at? And then for how long should we give this? The trial or the case that I showed you, there was no recommendation. So the phages that they were giving was not based on clear recommendations or guidelines. So this is a very nice review article from 2019. It looked at data from 1924 up until 2016. So when we look at bioavailability of phages, we know it's very good if you do it intravenous, even intramuscular, subcutaneously, or intraperitoneal. Inhalation is also very effective, so intranasally or through endotracheal tubes. And then topical and oral is very low in terms of bioavailability. We know that gut survival for bacteriophages is very good. I mean, we've seen with metagenomics that our microbiome is filled with bacteriophages. So when it comes to topical treatment, they say the minimum effective dose is between 10 to the power of 7 and 10 to the power of 9 phage forming units per mole. In the case I showed you, they use 10 to the power of 8. So I guess they guessed the right answer. But at least from the literature, that is the correct dose to use. In terms of penetration of different sites and tissues, we know it has excellent penetration. Interestingly enough, it actually crosses the blood-brain barrier as well. So even with CSF infections, and it includes bone marrow, skeletal tissue, etc. Up until then, there was no confirmation of using it in bones and joints, but I think there's enough case reports and case series and anecdotal evidence to support that as well. Then, in terms of its clearance, so we know it's not cleared by the bladder. It's very effectively cleared by the spleen and the liver, and it is not a linear relationship clearance. So as time progresses, we see that clearance slows down. So to come back with those 1 or 2 questions I started with is 5 days enough? There's no evidence showing that 10 days has a better outcome. We know that they are self-replicating. One of the concerns is that if you expose them too long to the immune system, you can build up antibodies that can react to other phages as well, so they're epitopes, so they want to shorten that. And most of the authors feel that if you're going to keep the drains and the tubes in for too long, you can increase your chances of creating a nosocomial-related infection like a Staph aureus. So 5 days seems to be reasonable. In terms of the frequency, how often should we give it? Well, the half-life of most phages is up until 6 hours, especially our lumbar phages. So in this case, they gave a TDS. One could also argue that they should have given it 6 hourly. What's the role of a loading dose? That's interesting in itself. And why would that be beneficial? So I think there's a few reasons for that as well. So the first thing is that bacteriophages gets cleared by the immune system very effectively. Not just our innate immune with phagocytes and complement systems, but also antibodies-wise. So there have to be enough starting dose or loading dose high enough to not be cleared by the immune system immediately. Secondly, we also have to remember that the bacteria is replicating exponentially. So we must have enough bacteriophages to overcome that exponential growth of the bacteria. Otherwise, we will be chasing our own tail. So I think there's enough evidence for us to be giving a loading dose to these patients as well. So you can say, Stefan, this is really beautiful. It brings a tear to my eye. I'm an orthopedic surgeon, does this work in real life? And this is a CID article from 2019. They looked at over 1,000 articles, included 30 studies here that they felt had the right inclusion criteria for them, and they almost found the efficacy of 90%. So something that my grandfather always tells me, and you know, you can say, you know, let's stop the shenanigans here. I mean, stop throwing high impact factor journals to me with all of these p values and confidence intervals. And my grandfather is a person that says, show me, I want to see it. I want to see it with my own eyes. And I think if I can't convince you of this last picture, I will probably never be able to do it. So this gentleman, he lives in Tbilisi, which is the capital of Georgia, and he was in a mine explosion injury, and he almost lost his whole limb. In fact, they were at the point of doing salvage therapy on him, and it's one of those cases where you can see the tendons and bones exposed, multi-drug resistant organisms, osteitis. You know, it's one of those cases in the wards, you don't want to look at it, but you also want to see the tendons in the explosion areas. And Bacteriophage was the last option for him. And sorry for the quality, so this comes from the journal directly. So you can see here the tendons, bones, soft tissue exposure. And here is the little cannula where the Bacteriophage solution is injected. And he received it in this case for 10 days. And from only in 8 weeks, we see a complete recovery, 8 weeks, from a point where we say we're going to take your limb to salvage therapy to almost complete healing. Yeah, and that's basically my story in a nutshell.
Well, thank you very much. It's interesting. I just ask you, I mean, how do we now start? Well, first two things. You say they're alive.
Yes.
I thought you just explained to me,
yes.
You know, a virus being alive, I don't quite understand it. But secondly, how can we be sure that they are static? They're not going to transform, or like the COVID virus, for instance, you know, a change. And how can we be sure that the binding mechanism doesn't change, so they don't start attacking other cells? I mean, how do you know, why would this be a stable virus, yet the COVID virus, and so with HIV virus changes so much?
Yeah, so there's always a potential that they can mutate as well. I mean, theoretically, that's always a possibility. But what they do when they select a phage library is they get whole genome sequencing, so they first of all make sure there's no resistant genes within them. And what they also sometimes do is they use a cocktail of polyphages. So not just one phage, but a combination of them together to try and overcome that mutation of taking place against the one phage. So that's also implemented in practice that we see quite commonly. But definitely theoretically that's always a concern in terms of safety. And I think that's why so many of the trials suddenly stagnated at phase 2 trials, is they first want to ensure it's safe. Yeah.
So being alive, why is it alive?
Yeah, so that's probably not the right choice of words. Yeah, I guess, I'm not sure if you can call it alive. I understand the question.
Yeah.
It's not a medication, it's a virus. It's biological.
I mean, it can't replicate itself, fact. It's a piece of coding that needs itself to replicate.
Yes, exactly. It takes over the machinery for the transcription and translation. You're 100% correct. So it was maybe a poor choice of words.
There's some hands up here, but there's also just some questions in the chat. So Tom asked whether it's available at Grooteskies. So I said, unfortunately, not yet. And then Sean asked, what is the dosing recommendations based on, and how is the phage concentration for PK measured ex vivo? How is it determined in plasma and in tissue?
I think that's a very good question. I think we spoke about it a little bit last week at the ID meeting as well. And that's currently a concern with bacteriophages, is that the PK/PD studies is lacking behind a little bit. One of the concerns as well to that is that can we really compare different phages against one another? Can you elaborate the PK/PD of one phage or for one type of bacterial infection to the next one as well? So I think there's a lot of research currently taking place to investigate that a little bit better. And I don't think there's conclusive answers to that as yet. Just to answer Sean there as well, so the one for the topical minimum effective dose is in animal models, and for that one specifically it was chickens and rats that they did that in for a specific bacteriophage. But can you really elaborate that or extrapolate that to a different bacteriophage? Yeah, I think the jury is still out on that, and there's still a lot more research needed.
Yeah,
Sean, yeah, sorry, maybe you can elaborate.
Thanks, Stefan. A really entertaining talk as always. So, I mean, the reason why I asked, I know I asked this last week, and thank you for elaborating on it this week. But the reason why I'm asking again is because, like, the information that you shared was based on a review article, and it had very nice pictures of figures of human bodies and different colors and where the phages go and their PK, but like, what's it actually based on? And can you actually measure the concentration of these things from a blood or tissue sample?
So I think when it comes, and I hope I'm going to answer the question at least to some extent. I think the biggest problem with intravenous application of phages is that they cleared very quickly within the blood, and that's due to a few things. They dilute very quickly, they are captured by the reticular endothelium system, and then also what's the other component? They're cleared by the immune system. So half-life in the blood, they look about at 1.5 to 2 hours. So topically, as I showed with those pictures, it's the absorption is a lot lower. So half-life being a little bit extended, but maybe for Sean, I can go look at the article again and just give him a bit more clearer answers to that. But to the best of my knowledge, most of that just comes from animal models, and nothing extending too much into the human or primate criteria.
Prof. Brink, Prof. also has his hand up to ask a question.
Hello, Maritz. Yes, thank you very much, Stefan. Also for the opportunity to comment. I couldn't see who asked the previous question, but the problem with the phages previously had been that they can, if they are not purified and manufactured correctly, can in fact carry resistant genes and virulence genes with them, which they then transfer to the host, which then expresses those genes. So that's why the West has been very slow, besides PK/PD issues and so on, to have an increased kind of a taste for the bacteriophages. So the manufacturing process of purifying the phage and not having it encoding a virulence gene or a resistance gene is one of the problems regarding the old practices of manufacture. I sent Stefan a review that was published recently with the potential role in orthopedics. I see it didn't go through. So Professor Lapsha, I'll send it to you just for your records. It's a review of the last or all published orthopedic work on bacteriophages and essentially summarizes 9 different reports regarding the use of it in various kind of difficult to treat orthopedic infections, including prosthetic joint infections. Thank you.
Thank you. Someone question here, Aik?
Yeah, what I realized from your presentation, I think somehow you were almost convincing us that the Bacteriophage is something very nice and all these things. And I didn't see, when you put the comparisons between antibiotics and bacteriophage. You didn't put the roots of the use between what is the difference between the antibiotics and bacteriophage? That's the first question. The second question, if it is nice like this, why not you being used like antibiotics? And I can see from the questions there is not available in broad scale, but why not?
So just to get to your first answer, I think that bacteriophages and antibiotics would work together, so they will complement each other. And the idea behind using bacteriophages is in those isolates that span resistant. So where there's no antibiotics that's according to an antibiogram sensitive. So you won't use it just for all types of infections. It will be these multi-drug resistant infections that you would ideally implement it for. I think, does that answer your first question? Of when would you use bacteriophages instead of antibiotics?
No, what I was meaning is the root of the. I can see when you compare it, for example, when you compare all the comparisons. It was advantages of bacteriophage more than antibiotics. I mean bacteriophage more than antibiotics. So the roots, how do you use it? Is only IV, or do you have other
administration routes? Yeah.
Yeah. So
IV and local, as you said. Yeah.
So there's a lot of studies going, or that was previously done in the 1960s and for many years, where they used the IV route of administration for Salmonella and Staphylococcus aureus. So there's a lot of work on that used as well. There is a few problems with the intravenous use, like I mentioned, with the elimination of the bacteriophage and then dropping. But it seems like topical and use is very beneficial. It's dose dependent, so the higher the bacteriophage dose, the deeper the penetration into the soft tissue as well. But yes, it has been used intravenously, has been used inhalation-wise, as well as topical. So the one route it's not approved for is, or at least in theory, is oral, because the bacteriophage does not cross the mucosa, the tight junctions very well, and endocytosis is also very low through the mucosal layer for bioavailability. So that's the one route which you should not be using. With that said, its survival in the GIT tract is almost 100%, like I showed in the picture.
I think you had a question, and then Rob now.
Biologically, the definition of life must be able to reproduce and interact with the environment. So you can argue whether binding to protein and things interesting. A lot of parasites reproduce life, they need a host. Why don't phages dominate, for instance, staph in an ICU? What is preventing the phages from dominating and eradicating the staphylococcus colonies that happen to be there in the natural environment, besides injection of human?
Well, theoretically, you would think that that is possible, at least in theory. The only question is that, or that I can think of, is that the bacteriophage for that specific bacteria is just not present in that specific patient or the surrounding, at least. And that's when they selected from the phage libraries is a whole variety of different phages against that specific Staphylococcus aureus strain, and seeing which one of those utilize it. So coming back to your question, at least in theory it's possible, but the only explanation I can think of is that
So how specific are those? One immunostate is affected different to immunostate in none. So that's our phage not good for that one. Is that specific, or is it more specific than?
So it could be strain specific. So they have shown that it's not just species specific, it can also be strain specific, but it depends on your bacteriophage. So some of the bacteriophages will cover a whole species, so it will cover all the Staphylococcus aureus, but other bacteriophages even goes down to the strain level. It will not, cover all Staphylococcus aureus, but it looks for a specific strain, and that just depends on how good your selection is and in your laboratory or your phage selection. Yeah.
Well, so a big problem we have with musculoskeletal infection is getting the antibiotic to the infection. I mean, you're basically always with these well-formed abscesses. There's no blood going to supply. I mean, like now, I'm washing out a wound constantly. Antibiotics aren't really doing the job, even though the sensitivity in the lab is fantastic. It's not actually doing the job for us, and I think that's why your bladder washouts were as good or better than the phages. So obviously the phages provides, if it can multiply rapidly inside an abscess, it potentially could be far better than the antibiotic. So I'm just interested. So how many viruses will be replicated in a cell cycle versus the cells developing? In other words, are you going to create more phages than the number of cells developing as one? And then the impact of certain antibiotics messing with the metabolism of the cells, stopping the phage being made. I mean, is there a problem that antibiotics may make the phage action, inactivate the phage action? And I mean, and just the relationship of the metabolic cycle to make the phages versus making more bacteria. How is that related? I don't know how quickly it happens.
So in terms of the antibiotics interfering with the replication of the phage inside the bacteria, I haven't came across any literature that specifically addressed that issue. Obviously, I will read a little bit up and then feedback to the department as well, but I haven't come across anything where those interfere with one another. And secondly, in terms of the bacteriophages themselves, the cycles. So this is also dependent on the type of selection of the bacteriophage. Not all of them has the same. When I gave that initial slide where we looked at the phage library, specifically the burst size, and also the spectrum of activity of the bacteriophage. So not all bacteriophages will produce the same amount of virals or the burst size that they would like to call it, the jargon terminology. So that's one of the criteria for when you select a specific phage. You want one that for your specific organism has a nice big burst size with a lot of virals produced. So that's one of the selection criteria you will actually look out for in the laboratory, because they're not all equal.
Very brilliant.
Prof, did you have another comment, or was your hand still up?
Maybe it's high five?
Yeah, high five to Stefan.
Thank you.
No,
Yes,
I
go.
actually just, in support of what Stefan said, great overview. Thank you, Stefan, in a complicated topic. To answer the question, I don't know who asked it previously, Maritz. One needs to understand that the bacteriophages are self-limiting. So they require the host target bacteria, the MRSA or whatever bug, to constantly grow. And if the bacterial pathogens that are specific for are absent, they will not persist long, if that makes sense. So the big advantage is that replication at the site of infection is probably the most major and most important advantage, because they go wherever the target bug is that you're targeting, and irrespective of where it is, it can get through the biofilm and it will continue self-replicate as long as the bugs are alive. Until they're all dead, then it basically stops persisting.
Yeah,
that makes sense.
Yeah, thanks. Thank you very much. Steve, you want to?
Yeah, thanks for an excellent afternoon. With all the anti-vaccine people that are around at the moment, I'm sure the next question is, how do we know we're not going to get those phages jumping into the other cells and changing us to mutate like the District 6 or the District 9 movie, either killing us or changing the DNA in the other cells?
Yeah, so I think with one of the big advantages of the bacteriophage is its narrow spectrum of activity, so that absolute specific binding of the fibers towards on the bacteria cell wall, and those antigens on the bacteriophages is fundamentally different than what is on mammalian cells. So the structures we find on pili or flagella or the porins, so there's a very high specificity in terms of the binding, and that not influencing the human cells, if I can say. But that's also important when it comes to, I think the selection of your specific bacteriophage that you want to use in the patient, and that's absolutely critical, is that it must be very specific, and to avoid collateral damage as well, not just towards the bacteria, but also the normal microflora that you would try and keep intact in that specific area.
Thank you very much, Stefan. It was fantastic, even managing to explain it to orthopods to a level where they can more or less understand it. So I'm just going to briefly present on phages in orthopedics, and the presentation is very short because there isn't much. We had the honor of having Andre Trumpusch from the Charité Institute in Berlin at our Orthopaedic Congress 2 years ago. And most people won't know it because, like always, the infection sessions were very poorly attended. But he presented some of his research with phages, and I was sort of blown away because it's almost too good to be true. Something that kills bacteria and then ceases to exist when the bacteria is killed. And anyway, so unfortunately, all this sort of research is not in its infancy because it's been around for a long time, but very limited. There's recently been this review published in the BJJ, which we all read, just sort of summarizing the orthopedic literature in the English-speaking world. So just obviously there's scary numbers of the future with the increase of antimicrobial resistance. And in orthopedics, there's also a worldwide trend to increase of infections. Actually, the incidence of infection in orthopedics have decreased over the last decades, but the increase in infective cases have drastically increased, and that's just because of more surgery being performed. And the staggering number that at the moment there's more than 1 million total hip and knee arthroplasties a year performed in America. And if you just work on a PJI rate of 0 to 4%, you can just calculate the number of prosthetic joint infections. And then there's an increase worldwide of infections with antimicrobial resistant organisms. So we're not one of the biggest users of antibiotics in general in orthopedics compared to other specialties, but we disproportionately use this sort of restricted antibiotics in these resistant cases. And that's why we also have an important role in antimicrobial stewardship, not only in general, but also for our own cases, because often cases end up with resistant organisms because of early poor management, both surgically and when it comes to antibiotics. So local therapies in general, not just phages, are very attractive, both local antibiotics and phages, because it avoids some of the complications or side effects associated with systemic therapy. There's very limited evidence when it comes to bacteriophages. Most of the available evidence is in non-orthopedic fields. Currently, there's 42 studies registered on clinicaltrials.org around bacteriophages, none of them on orthopedic studies. So just looking at the orthopedic evidence, there's very few studies. If we look at animal studies, there's only 6 in the English-speaking literature, and it shows potential effectiveness against a biofilm if applied locally. Most of these studies are implanted of a device coated with phages into an animal bone, and then looking at an inoculation of bacteria, and then looking at the decreasing the number of bacteria in the area. And they've shown in animal studies efficacy against specifically Pseudomonas and staph organisms. In the lab, also few orthopedic studies. One of the studies, that's just because it's quite relevant to us, they used a titanium scaffold and had the biofilm-based infection adhere to the titanium scaffold, and then with phages specific to Staph aureus showed a 90 to 100% reduction in the bacteria count. The effect is also dose dependent. And a lot of it's not known. If you look at the clinical studies in orthopedics, it's all summarized on this one page, and it's all small case series of either 1 or up to 9 cases of often varying pathologies treated with phages. But what's quite encouraging is all of these are really in-stage cases. Sometimes people have had failed treatment for months, long duration of antibiotic therapy, and multi or extensive resistant organisms successfully treated with phage therapy. So you look at the earliest clinical studies, this is not orthopedic specific, from Poland that looked at 236 patients. This is a mixture of infection and central nervous system infections, lung abscesses, and some orthopedic infections that showed a high success rate. Probably a lot of the publications is from Poland, from this specific institute, and they published 40 cases of long bone chronic osteomyelitis treated with phages. There's not very good information about the surgery and the associated antibiotic therapy in conjunction with the phages, but they showed a 95% success rate, which of course an infection is very, very good. And like I said, most of the recent publications is small case studies or case series. Just to show, because in orthopedics we battle to understand something without pictures, and this is just one case from Alexander Trumpush that he presented, where this is a patient, a 42-year-old, with a bicondylar open tibial plateau fracture that was plated and complicated by infection, long months therapy with different antibiotics, and ended up with an extensive resistant Acinetobacter and Klebsiella. And this patient had 2 5-day courses of local application of phages over 2 weeks and healed. And in this case study, this is at 10 months, because like anything in infection, you know, initial, because there's obviously a lot of recurrences, you need at least long-term follow-up of preferably a year before you get excited, but 10-month follow-up showing no infection. So there is some, even though the evidence is limited, it's encouraging. So just to conclude, there's very limited evidence for phage therapy, but it may offer a solution for ortho implant related infections, specifically the sort of multi-resistant organisms ones where conventional therapy fails. And it needs ongoing research. And then just interestingly, or very exciting, that we can say that we have a local microbiologist who's very interested in phages and who's made some initial inquiries about importing phages and starting some local research. And we're just looking at starting the first steps of some local research on phage therapy. Of course, it's a long road through ethics, and we'll need SAPRA application as well, but we're looking in the near future to do some local research on phage therapy for orthopedic infections. Thank you very much.
So we'll move your office away.
Michael.
It's there already, so you're saying it's new for orthopedic surgery to do this research here, but